Thank you, sir. So, this is a case scenario, and I'll try to show you different types of cases pertaining to this topic. So, if you look at this patient who's a 48-year-old gentleman admitted in the critical care unit in the CCU with a poorly defined ill health, we don't have much information available through the relatives, no significant past history, and you've been called to do an echocardiogram in this kind of a patient. So it's a wide open field where you have to do a lot of lateral thinking and then, zoom into the diagnosis. Now, if you look at the shock as such can be divided into 4 types. One is the hypovolemic, where you had a blood loss or significant water loss like diarrhea, etc. It can be cardiogenic, which is pertaining to the heart, and we'll discuss that. Distributive, where there is a significant vasodilatation, peripheral vasodilatation, where the SVR or systemic vascular resistance falls significantly, like in sepsis. And obstructive, where you have pulmonary embolism, tension pneumothorax, tamponade, etc. So these are your 4 basic types of shock which can be seen. When you talk about cardiogenic shock, traditionally we've been told that if the blood pressure falls below 90 millimeter of mercury systolic, that's when you would label it as shock, which is partly true. But what has now been seen, and the thought process which is developed, is that it's not the blood pressure, but the concept of hypoperfusion of the tissues, which is a defining criteria for shock. You can actually have a normotensive cardiogenic shock where there is hypoperfusion without any hypotension. So the blood pressure would be higher, still higher than 90, still the patient may be hypoperfused. And these patients, even if they have normotensive cardiogenic shock, they have high mortality, almost similar to the hypotensive classical cardiogenic shock. Now, what does hypoperfusion do to us? So if you look at the clinical signs of hypoperfusion, you would have cold, sweaty extremities, there will be fall in the urine output, mental confusion, dizziness, and narrow pulse pressure. If you look at the biochemical tests, you would have elevated serum creatinine, which a lot of us label as acute kidney injury, metabolic acidosis, lactic acidosis, and these all reflect tissue level of hypoxia and altered metabolism. So in a nutshell, cardiogenic shock is nothing but a progressive cycle of inflammation, ischemia, vasoconstriction, and volume overload, eventually leading to multi-organ dysfunction and death. It is a time-sensitive, hemodynamically complex syndrome and can have very wide variety of etiologies, which I will show you. And despite the latest advances, still the mortality of cardiogenic shock remains close to 40%. If you look at US, the mortality, in-hospital mortality is still 37%. In Europe, it is 30 to 60%. And the major cause of this is the acute coronary syndromes. The females, blacks and Hispanics have higher mortality and have less revascularization or MCS. So this is the classification which was given by the SCAI, where the A, B, C, D, E are the categories which are progressively exponential in terms of the severity of cardiogenic shock. So at risk is A, and then you have hypotension without hypoperfusion. You have classical hypotension and hypoperfusion, which is C, and then further escalation leading to what is known as E or extremis, which is the hemodynamic collapse. So you can see that even when the blood pressure is normal, what we call as a if the blood pressure is not less than 90, this is not a cardiogenic shock if the perfusion is maintained. But as the perfusion falls, that's when the risk category increases. So it's the hypoperfusion and not the blood pressure which matters. Now, there are many guidelines which have been given for cardiogenic shock, but we will not go into the details. But in the nutshell is what I have described to you as the concept. Now, if you look at the etiology or epidemiology, Maximum is acute coronary syndrome related. Nearly 60 to 80% is because of ACS. And out of that, most of them are ST elevation MIs. So you can see that still what you will get in your clinical practice with cardiogenic shock is the acute coronary syndrome. Now, how do you evaluate these people when you come across somebody who is in shock? So you look at the history. Somebody may have high-grade fever. Somebody may have very clear signs of sepsis. Somebody may have an underlying connective tissue disorder. So history is very, very important. The chest pain, breathlessness, sudden onset, slow onset, or gradual onset, all this will matter. Of course, the physical examination will give you an idea about the JVP, the pallor, the perspiration, edema, bilateral basal creps, etc. And then you look at the hemodynamics, the saturation, you look at the blood pressure, heart rate, and of course the ECG and urine output. In the non-invasive monitoring, you have the echo and ultrasound, what we call as the POCUS and VEXUS, and then invasive is transesophageal echo, and then hemodynamic invasive monitoring. For echo, you can, I will show you examples rather than describing it to you in a slide. So you can actually look at hypovolemia or tamponade physiology, LV systolic dysfunction, RV systolic dysfunction, or valvular pathology. But there is also a role for what is known as supportive therapy, supportive imaging. So you have the lung ultrasound, where we can actually look at the upper quadrant of the chest. This is how we divide it into 4 quadrants. And we look at the chest wall and the lung shadows. So if you look at a pulmonary edema patients, this is the B lines, which you can see here. Multiple B lines. This is the normal A lines, which is the air. And this is how the B lines of pulmonary edema in lung ultrasound looks like. If you look at a lung ultrasound versus CT scan, you can see that in a same patient who has pulmonary edema, you can have this is kind of a, you can see the B lines here, and of course B lines on the ultrasound. This is pleural effusion. If you have ARDS, you can actually see less B lines, but more of subpleural consolidation pattern. There is another very, very important aspect which most of the people don't look into, is the venous congestion or the organ congestion. So you have to look at the hepatic venous flow, which becomes, as the severity of hepatic congestion occurs, the IVC becomes full, hepatic veins dilate, and the systolic flow reversal occurs due to progressive decline in right atrial compliance. You can also look at the portal venous flow, which progressively becomes increasingly pulsatile. Normally it is flat like this, but it becomes increasingly pulsatile as the congestion increases. And then the intrarenal parenchymal vessels, which can also show you a monophasic pattern when there is a congestion. So these are some of the additive findings which can help you define if somebody is having pulmonary edema. Now, echo should be done as early as possible without wasting time, because you can pick up complications of acute coronary syndrome or MI, like the ventricular septal rupture, cardiac rupture. You have patients coming with ruptured chordae or papillary muscles with severe mitral regurgitation. You have a patient who's come with lateral wall rupture here. You can see a clear-cut rupture in the lateral wall with large pseudoaneurysm. You can see this is the rupture and large pseudoaneurysm which can be seen. So these patients present to you with severe hypotension and hypoperfusion. This is a RVMI, where you can see a dilated hypokinetic right ventricle, again presenting with shock. This patient underwent a PCI and after a few hours developed hypotension. And here you can see in the plaque view that there is a large hematoma which is compressing the right ventricle. You can see it better in the transesophageal image. So this is the hematoma which is compressing the right ventricle post-PCI and causing shock in this patient. You can see a very large hematoma here. He had to go for surgery. Now, these are some of the cases which I picked up from my own practice. So this is a 57-year-old male who presented in the emergency with progressive angina and dyspnea. And if you see, he has already had an evolved large anterior wall MI. When we did the angio, we can see a completely 100% blocked LAD. Now, most of the times when they go for primary PCI or a rescue PCI, nobody does an echocardiogram in most of the cath labs. Now this patient went for a angioplasty, and you can see the stent has been placed. And the flow is pathetic. I mean, it's really, the flow is hardly there. And this is the final, you can see that there is a slow flow in the LAD territory, hardly effective. But what is most important is the echo. You can see that at the apex, there is what is known as the intramyocardial dissecting hematoma. You can see these islands of echolucency. This is not a clot. This is an IMH, or intramyocardial dissecting hematoma. This is the dissection flap here. And this is something which means that it's a transmural infarct, and these patients will not benefit from revascularization. If the echo had been done prior, we probably would have spared the patient with a stent, from a stent. So this is the classical hallmark, a systolic expansion, intact epi and endocardium, and a dissecting flap. And on a 3D, it looks like this. You can see the hematoma here, and this is what a gross specimen looks like of a dissecting hematoma. This is another patient of dissecting hematoma, has developed a pseudoaneurysm, and these are the patients who then go for surgery in most cases. So you can see this is a contrast. This is the entire dissecting hematoma, very well defined on the cardiac MRI as well. So the management is depending on the size and the hemodynamic condition of the patient. If the patient is, if IMH is small, then you remain at conservative management. If it is large, you go for surgery. Angioplasty has very limited role in this. Then other causes of shock can be a stuck valve. So this is a bileaflet valve where you can see one leaflet is completely stuck due to a thrombus. These patients can go for surgery or thrombolysis depending on the clinical condition and the amount of thrombus which is available, which is present on the valve. These are infective endocarditis cases leading to severe mitral regurgitation. This is another case of perforation. You can see severe mitral regurgitation. This is the 3D where you can see an en-face view of the perforation. Now this is another case of sepsis coming to us with hypotension and shock, cardiogenic shock, and here you can actually see on transthoracic echo a sepsis of, this is the stent, which you can see here, and there is septic shock because of the infection of the stent itself. So the stent abscesses can be picked up sometimes on echo, but mostly on CT. Now this is another case of a post-peripartum sepsis in a patient who came with large vegetations on the tricuspid valve and cardiogenic shock. So you can see these large vegetations, severe tricuspid regurgitation. She had to go for surgery with tricuspid valve replacement. These are some of the other cases of infective endocarditis where ruptured chordae, flail, AML, and severe mitral regurgitation. Then of course you have the large pericardial tamponades here with Medusa head-like picture here. And these patients, of course, would be coming to you with cardiogenic shock, with low pulse pressure, and would require an immediate intervention with pericardiocentesis. Now, sometimes you may have infiltration of the chambers by sarcomas. Like in this case, you have a large sarcoma which is infiltrating the heart posteriorly into the LA. Patient presented with hypotension and cardiogenic shock. So this was a CA lung presenting with LA infiltration. Now, some of the very interesting and important conditions which come to you with shock in the CCU are the connective tissue disorders. For example, the rheumatological conditions. So if you look at this paper in 2023 in Heart Failure Reviews, most common was the SLE and EGPA, and of course the APLA and other like the giant cell arteritis, etc. were also some of the conditions which cause cardiogenic shock. Now, I'll show you some examples from my own clinical practice. This patient presented with severe LV dysfunction, acute decompensated heart failure, and had a large left atrial clot as well. This patient turned out to be SLE. You can see large LA clot along with severe LV dysfunction. And some of these patients present with hypercoagulable state. So you can see biventricular large clot along the apex and also in the right ventricle here. So these patients have severe LV dysfunction along with significant, so some of them actually turn out to be secondary APLA with hypercoagulable state. Some of these patients who present with cardiogenic shock can have EMF. So you can see both biventricular EMF in this patient, both the RV and the LV apices are obliterated. So going forward, another important condition is APLA, or antiphospholipid syndrome. So this was a 29-year-old gentleman who presented with gangrene of the feet, and he had been treated earlier for the peripheral vascular disease. He had history of pulmonary embolism in the past, and this was his echo. So you can see that there was a wide open TR. The tricuspid valve was completely organically damaged, and severe TR was there, tricuspid regurgitation, which was low pressure. And this was the 3D picture, wide open tricuspid valve with no coaptation at all and severe torrential TR. And when the investigations were, the antiphospholipid antibodies were positive, so this was a classical APLA. Another female, 50-year-old, who had lipodermatosclerosis and paniculitis in the past with venous thrombosis, presented few years later, and this was the echo. There was a very unusually large clot on the AML, you can see here, and patient presented with significant shock later on and stroke. So this was how the valve looked like, and this is the 3D picture of the valve. You can see that this was a large thrombus which was actually on the AML, adherent to the AML. So this was, again, an antiphospholipid syndrome, but the antibodies were negative, so this was a seronegative APLA. I'll take you to CKD patients who come very often to CCUs and are on dialysis. So this patient was 67-year-old diabetic hypertensive CKD and was in shock. So when we did the echo, there were multiple findings in this patient. You can see that there was pericardial effusion all around. The LV dysfunction was present, especially the apical ballooning, which you can see here. And there was also this faint shadow of the catheter-related atrial thrombus, or CRAT, as we call it. So this is what patient had: ballooning, apical ballooning syndrome. There was the CRAT here. You can see this. I'm not sure if you can see the shadow here, but this is the CRAT. I can show you in this. This is much better seen. So this is called catheter-related right atrial thrombus, and of course the pericardial tamponade as well. So this patient had all the three findings in one. So this is what a CRAT looks like: thrombus attached to the permacath. So then comes to sarcoidosis. These patients can also sometimes present with acute decompensated heart failure. For example, this patient was initially diagnosed as non-compaction LVNC, but actually turned out to be sarcoidosis. So this is the 3D rendition of it. And this is another case who came to me with heart failure with reduced ejection fraction. Initially, you can see the PR interval is greatly prolonged. You can see here the PR interval is greatly prolonged. And the patient had typical aneurysm at the apex, and also the basal segments had aneurysm. So this was actually a patient of sarcoidosis with severe mitral regurgitation. We started her on steroids, and she actually became much better. The mitral regurgitation became less. This was her initial FDG PET picture with the septum being involved predominantly, which was explaining the prolonged PR interval. So once we gave her the therapy, her EF improved from 30-35 to 45, the MR decreased, and the PA pressures decreased. She had a relapse, so we started her on infliximab. And this was after a few months. You can see there is a total resolution of the inflammation on the FDG PET, completely gone. Then this patient presented with a recurrent VT of LBBB with inferior axis morphology. He had an ICD earlier, and this was a case of ARVC. You can see large aneurysms at the apex of the RV and lateral wall with severe non-coaptation of the tricuspid and severe TR. So these patients also present with shock, sometimes refractory to any treatment and require transplant or what we call as a mechanical circulatory support. And other causes of shock can be aortic dissection. You can see a dissection flap here. Like this one, this is a dissection flap. You can have pulmonary embolism with thrombi which are sitting on the right ventricle and in the pulmonary artery at the saddle thrombus. You can have raccoon eyes, patient of amyloidosis who can present with shock, when they decompensate. So this is a classical picture of a patient of amyloidosis. So these are some of the other causes where patient can present with shock, with different etiology. This was a very interesting case. 18-year-old boy with history of seizures right from childhood, and had multiple seizures since the last 13-14 years. He had lactic acidosis in CSF, lactates were raised, and there was basal ganglia calcification on MR and CT. And this was his LV. You can see that there was a severe LV dysfunction, large clot, and this patient actually turned out to be what we call as the mitochondrial encephalopathy with lactic acidosis and stroke-like episodes, or MELAS, the mitochondrial disorders. So, in a nutshell, you can have so much variety of cases coming to you in your CCU, which can encompass the entire spectrum of diseases. How do you manage them? So if somebody comes to you with ACS, you would do coronary revascularization, you would give inotropes and vasopressors. In extreme cases, you would go for what is known as the acute mechanical circulatory support. And the most important is the concept of shock teams, which is very, very important, where the people who do their work the best are coming together to treat very sick patients. So this is what a multidisciplinary shock team looks like, which is a hub and spoke model. So you have, at different levels, you would have interventions and appropriate treatment. So the best inotrope is the norepinephrine in these cases. If there is cardiorenal syndrome, please remember that when you give diuretics for a long time, they may go into diuretic escape. Just 2 minutes more. And these patients can be treated with escalating doses of diuretics. You can add spironolactone, or nowadays SGLT2 inhibitors are also being used in these cases. So the last 2 slides are about MCS, or mechanical circulatory support. If you look at the Texas Heart Institute protocol, they look at the basic parameters and then determine which kind of an AMCS they can put in. And that is done by the shock team or the heart team. The device selection can be dependent on left ventricular, right ventricular, or biventricular failure. And these are some of the Impella RP, Tandem Heart, VA ECMO. These are for right ventricle. And for the left ventricle, you have IABP, Impella, and Tandem Heart, LA, which are available to you. So, take-home message: cardiogenic shock kills. You need multimodality imaging, especially echo, which is needed early and repeated often. And shock teams are a must to save lives. Thank you.